Hello, today we're going to talk about disorders of fluids and electrolytes, an integrated view of potassium homeostasis. First, we want to talk about the definition. Total body potassium stores are approximately 3,000 milliequivalents or more, 50 to 75 milliequivalents over kilograms of body weight. In contrast to sodium, which is the major cation in the extracellular fluid and has much lower concentration in the cells, potassium is primarily an intracellular cation. With the cells containing approximately 98% of body potassium, the intracellular potassium concentration is approximately 140 milliequivalents over liters, comparing with 4 to 5 milliequivalents over liters in the extracellular fluid. The difference in distribution of the two cations is maintained by the sodium-potassium HCPase pump in the cell membrane, which pumps sodium out of the cell and potassium into the cell in a 3:2 ratio.
Sodium and potassium are the two most abundant extracellular and intracellular ions, respectively. For example, the typical extracellular sodium concentration is 140 milliequivalents per liter, while the intracellular sodium concentration is about 12 milliequivalents per liter. On the other hand, intracellular potassium concentration is about 150 milliequivalents per liter, while the extracellular potassium concentration ranges between 3.5 to 5.5 milliequivalents per liter. All right, now that we know that, let's ask this question. How are these concentration differences between the intracellular and extracellular compartments established for sodium and potassium ions? Well, the concentration differences are established by the sodium-potassium ATPase. Now, the sodium-potassium ATPase transports 3 sodium ions from the intracellular fluid compartment to the extracellular fluid compartment in exchange for 2 potassium ions. Also, these concentration differences play a central role in establishing the resting membrane potential. For example, an intracellular and extracellular potassium concentration of 150 and 3.5 milliequivalents per liter yields an equilibrium potential of minus 95 millivolts, while an intracellular and extracellular sodium concentration of 12 and 140 milliequivalents per liter, respectively, yields an equilibrium potential of plus 60 millivolts for sodium. However, because the cell membrane is mostly permeable to potassium, as denoted by the presence of this potassium ion channel, the resting membrane potential for most cells is approximately minus 70 millivolts, which is closer to the potassium equilibrium potential. Now, because the cell is mostly permeable to potassium ions, it means that changes in intracellular and extracellular potassium ion concentration will have a more profound effect on the resting membrane potential than changes in the intracellular and extracellular sodium ion concentration. For example, increasing the extracellular potassium concentration from 3.5 to 8 milliequivalents per liter causes the resting membrane potential to become less negative. In other words, it shifts it from minus 70 millivolts to approximately minus 50 millivolts, while the potassium equilibrium potential shifts an equivalent amount. In other words, from minus 95 to minus 75 millivolts. So, what effect does a less negative membrane potential have on the body? Well, making the membrane less negative makes cells less excitable, which can have a profound effect on cardiac conduction, neuromuscular activity, and vascular resistance, just to name a few. Therefore, maintaining extracellular potassium within its normal range is critical. For example, an extracellular potassium concentration of less than 3.5 milliequivalents is considered low and is referred to as hypokalemia, while an extracellular potassium concentration between 3.5 and 5.5 milliequivalents is considered normal. And finally, an extracellular potassium concentration greater than 5.5 milliequivalents per liter is considered high and is referred to as hyperkalemia. Okay, now that we have that out of the way, let's ask our final question. What factors determine extracellular potassium concentration? Now, there are 3 important factors that determine extracellular potassium ion concentration. First, the movement of potassium ions between the intracellular and extracellular compartments. Second, potassium intake and absorption along the digestive tract. And third is the excretion and reabsorption of potassium by the kidneys.
Okay, next we want to talk about the applications in medicine. In normal individuals, dietary potassium is absorbed in the intestines and then largely excreted in the urine, a process that is primarily determined by potassium secretion by the principal cells in the tube segments that follow the distal tubule. The connecting segment is a cortical collecting tubule. The three reasons that affects the potassium in the body and excretion in the body is an increase in plasma potassium concentration and or potassium intake, an increase in aldosterone secretion, and number three, the enhanced delivery of sodium and water to the distal potassium secretory sites. Ingestion of potassium leads initially to the uptake of most of the excess potassium by cells in muscle and the liver, a process that is facilitated by insulin and the beta-2 adrenergic receptors, both of which increase the activity of sodium-potassium ATP-based pumps in the cell of the membrane. Some ingested potassium remains in the extracellular fluid, producing a mild elevation in the plasma potassium concentration.
Between potassium and hydrogen. So as we know, hyperkalemia is associated with metabolic acidosis, whereas hypokalemia is associated with metabolic alkalosis. So let's talk about hyperkalemia. So when our plasma is full of potassium, which means the extracellular compartment is full of potassium, some of the potassium will try to enter into the cells. And as it does that, the cell says, there's a lot of positive things coming in, so I need to get rid of some positive stuff. And it will kick some of the hydrogen out. So extracellular potassium moves intracellular at the cost of intracellular hydrogen moving on extracellular. And as extracellular hydrogen goes up, we get more acidotic. The second mechanism is, I think, what's the main mechanism for excretion of potassium by the body? So I think mainly it is under the influence of aldosterone that happens in the collecting duct in the kidney. So let's just remind ourselves. Aldosterone reabsorbs sodium from the principal cells in kidney, and at the same time, as the urinary lumen says, okay, you've taken away a lot of positively charged things, please give me some positively charged things in return. Aldosterone also helps to kick out potassium into the urinary lumen, but it's not a strict one-to-one thing. So what happens is aldosterone brings in more sodium than it kicks out potassium. So the urinary lumen says, I need some more positive things, please. And then a bit of hydrogen leaks out through the intercalated cells into the urinary lumen. So directly, aldosterone causes potassium excretion, indirectly it causes hydrogen excretion. So when you've got hyperkalemia, the tubules will try to get rid of potassium at the cost of hydrogen. So hydrogen is staying back because more potassium is being excreted. So that's the second mechanism. And I think the third mechanism is, if we are acidotic due to any cause, our kidney will always try to get rid of the hydrogen. But you need a buffer in the urine to neutralize that hydrogen, otherwise urine will quickly become saturated with hydrogen and will become extremely acidic. So ammonia is one of the major buffers in the urine. However, hyperkalemia actually inhibits the production of ammonia in the kidney. And as there is less ammonia, hydrogen cannot be excreted because you don't have enough buffers. So the point we're trying to make is hyperkalemia leads to metabolic acidosis, and it's the other way. Hypokalemia leads to metabolic.
Now, pros and cons. The most rare manifestations of hyperkalemia are muscle weakness and paralysis, cardiac conduction abnormalities, and cardiac arrhythmias. These manifestations usually occur when the serum potassium concentration is more equal to 7.0 milliequivalents over liters with chronic hyperkalemia, or possibly at lower levels with an acute rise in serum potassium. Patients with skeletal muscle or cardiac manifestations typically have one or more of the characteristics of electrocardiogram abnormalities associated with hyperkalemia. A hypokalemia cause is an effect most prominent after the administration of exogenous insulin to patients with diabetic ketoacidosis or severe non-ketotic hyperglycemia, who are often normokalemic or hyperkalemic at presentation, even though they have lost potassium. Hypokalemia can rarely result from an insulin overdose.
Well, 80% of the filtered potassium load is reabsorbed along the early and late proximal convoluted tubule. 10% is reabsorbed along the thick ascending limb, 2% is reabsorbed along the initial and cortical collecting duct via alpha intercalated cells, and 6% is reabsorbed along the medullary collecting duct via alpha intercalated cells. Now this means that approximately 2% of the filtered potassium load is excreted by the kidneys. So let's ask this question. Now reabsorption of filtered potassium along the proximal convoluted tubule occurs paracellularly, driven by solvent drag in the early portion and a lumen positive potential in the late portion. Now solvent drag accounts for most of the potassium reabsorption along the proximal convoluted tubule. And as a reminder, solvent drag along this nephron segment is dependent upon sodium reabsorption. Reabsorption of potassium along the thick ascending limb occurs equally between transcellular and paracellular pathways. Now, the transcellular reabsorption of potassium occurs via the sodium-potassium 2-chloride cotransporter. The apical potassium channels serve to recycle potassium, and without this source of potassium, the sodium-potassium 2-chloride cotransporter would cease to function, or function at a lower rate. Now, paracellular reabsorption along the thick ascending limb is driven by a lumen-positive potential, which is created by the differences in potassium and chloride permeability between the apical and basolateral membranes. Now, reabsorption of filtered potassium along the initial and cortical collecting duct occurs exclusively by alpha intercalated cells via a transcellular pathway. Now, transcellular reabsorption of filtered potassium occurs via the apical hydrogen-potassium ATPase, which transports one potassium ion into the cell in exchange for one hydrogen ion. This process requires energy in the form of ATP. Well, reabsorption of potassium along the medullary collecting duct occurs via paracellular and transcellular pathways. It also depends upon the upstream secretion of potassium by collecting duct principal cells. Principal cells secrete potassium into the lumen via apical potassium channels and concentrate the luminal potassium by reabsorbing water via water channels. Now, the increased luminal potassium passes into the medullary collecting duct, where it favors passive reabsorption via paracellular pathways and active reabsorption via the hydrogen-potassium ATPase. In addition, the reabsorption of luminal potassium along the medullary collecting duct contributes towards the recycling of potassium between the descending thin limb and thick ascending limb. And finally, as we mentioned earlier, under normal extracellular fluid potassium concentration, about 2% of the filtered potassium load is excreted by the kidneys, which means that of the 810 millimoles filtered, 16.5 millimoles will be excreted per day.
Now, issue applied in Ecuador. Allow dietary potassium intake. The ratio of dietary sodium to potassium intake can also influence blood pressure. Each 3-unit increase in the urine sodium to potassium ratio, which can reflect in increased sodium intake and or reduced potassium intake, was associated with a 1.6/1 millimeters of mercury elevation in blood pressure. A higher sodium to potassium intake ratio is also associated with an increase in overall cardiovascular mortality. So it is important to always see the relation between potassium and hypertension because of the high rate of patients with hypertension in the country. Conclusions. The increase in potassium intake alone is not a common cause of hyperkalemia unless it occurs acutely. The net release of potassium from the cells due to enhanced release or decreased entry can, and if large enough, increased tissue breakdown, cause a transient elevation in the serum potassium concentration. Persistent hyperkalemia requires impaired urinary potassium excretion. This is generally associated with a reduction in aldosterone secretion or responsiveness, acute or chronic kidney disease, and or diminished delivery of sodium and water to the distal potassium secretory sites. Thanks a lot. Thanks for your attention.